Hi, this is Jennifer Allen reporting for RSNA News. I'm talking with Dr. Vladimir Sheynzon, a vascular and interventional radiologist from New York Presbyterian, Columbia University Medical Center. We're talking about his experiences as part of a COVID-19 Surgical Workforce Access Team, or COVID SWAT team, that was briefly deployed to assist with patients at Allen Hospital in Manhattan. Thank you, Dr. Sheynzon, for joining me today to share your story.
Thank you for inviting me.
So first, I wanted to ask, what was the COVID-19 situation like at Allen Hospital when you arrived in late March?
In late March, the situation was very serious. As you know, New York City and New York State were particularly heavily affected by COVID pandemic, and Allen Hospital is located in northern Manhattan. This is the area that was affected very severely, probably one of the most severe affected areas in the whole New York City, and that says a lot. The situation at the Allen Hospital was under control, but we were looking at every area where we could get help so the situation would continue to stay under control. The number of cases was very, very high, and the daily case count was increasing, and we didn't know at the beginning when we would plateau. And so we had to deploy every possible resource that we had in order to try to keep up with the virus. It is interesting that Columbia's Baker Field, which is the Columbia's athletic complex, is right across from the Allen Hospital, and that was also converted into the field hospital by Columbia New York Presbyterian. There is a very large, winter training bubble, and that was converted into the field hospital.
So as a radiologist, how did you think you could help the most?
As interventional radiologists in particular, our role in general is to treat for critically ill hospitalized patients. During the pandemic, majority of the patients coming into the hospital were patients with COVID, and so we had to reconfigure our service somewhat in order to address the needs of those critically ill patients. In particular, many patients who were required, respiratory support and intubation would immediately need other critical care devices. For example, vascular lines, triple lumen lines, dialysis catheters. Many of those patients had COVID ATN or COVID kidney dysfunction, and they also needed arterial lines because many of them were septic and required inotropic support. And so all the ICU related lines needed to be placed into very large number of those patients, particularly mostly at the same time.
So can you talk a little bit more about the role of radiology on the surgical workforce access team?
Right. So interventional radiology is the branch or a field of radiology which is involved with minimally invasive treatments, and so we're particularly adept at endovascular work, and as such, we had the unique skills to help the intensivists in obtaining vascular access for these for the patients who were critically ill, sick with COVID. The main issue was that during the surge, many doctors who were hospitalists and other hospital physicians who don't routinely deal with critical care patients were redeployed into critical care areas in order to be able to meet the needs of those patients. And many of those doctors who were deployed to emergency room and who were deployed to ICU needed to be engaged in critical care decision making, and many of them were not have not practiced placing vascular catheters for many years, while we as interventional radiologists do that on a daily basis. And so we offer that unique expertise to those doctors and to those teams. And we placed those lines very, very quickly for each patient that required the line. And by doing that, we hope that we were able to offer we're able to offer to meet the needs that those patients had on a sort of very, very quick, very quickly.
So what impacted you most about this experience?
It's as part of the SWAT team, which was comprised of both interventional radiologists and general surgeons. We often have a friendly rivalry with other divisions, as it is true in many institutions. But it struck me how that was quickly set aside in order to meet this common goal of treating these very sick patients, and people stepped up. Even those doctors who were reserved and very quiet, very quickly stepped up and offered that service without a hint of reservation, even though it was a very, we felt was very dangerous situation with a virus that was highly contagious, and I did not see anyone, expressing any reservation and just doing the job that they had to do, doing their duty. And so that struck me how courageous the people were, even those that I did not expect to act that way.
So following your work on the SWAT team, what do you think is the long-term impact on both you and your department? What are the takeaways that you've learned?
I think there are two takeaways. The first takeaway is that when there is an unforeseen need, medicine is a very conservative field, and we often don't jump into implementing new solutions very easily. But I was pleasantly surprised of how quickly we were able to switch gears and offer innovative solution and innovative care when the need arose. And from putting together this the SWAT team to converting the ICUs, to converting the operating rooms to OR ICUs, the innovative solutions that were offered that saved many, many lives. The other interesting outcome, I would say, that came out of it is increased camaraderie between the departments. The interventional radiology and the surgery, as I said, often have a friendly rivalry, but this brought us much closer together. And so going forward, and I already have noticed that the relationships between the departments and the attendings in the departments have gotten much more personable. There is much more collaboration between the two departments, and it could be even manifested in a simple thing as a paper that we just submitted to the Journal of Vascular Interventional Radiology, which was a combined paper between the surgery and interventional radiology. It's not often that multiple departments collaborate on things like this so easily, and I think that's an outcome of working hard together in the trenches, being exposed to the same risk, and supporting each other at the worst time, at the time of need.
Well, thank you, Dr. Sheynzon, for your time today. For updates and the latest scientific research, guidelines, and consensus statements about COVID-19, visit rsna.org/COVID-19. And as always, you can find more radiology news at rsna.org/news.